I'm humbled and very honored to receive this prestigious award. I follow a long list of outstanding BYU faculty who have received this award, including one of my mentors, Aaron Bigler, and psychology colleagues Gary Burlingame and Brent Slife. I came to BYU in 1999 after graduate school at the University of Utah. BYU has been a wonderful place for me to grow and develop. I love research, teaching, and mentoring students. Today, I would like to share with you 5 lessons that I have learned over my research career. I received my PhD at the University of Utah, where I had the privilege of working with Raymond Kesner. Ray was one of the pioneers of the neurobiological basis of memory. He also pioneered comparative memory research in rodents and humans using analogous tasks. One of his goals was to use animal models to understand disorders in humans. Ray's research fit with my interest in the effects of hypoxia on the brain and cognitive function, with the focus on memory. My oldest son suffered an accident that resulted in lack of oxygen to his brain that left him with significant challenges. I checked the literature to find treatments to help him. What I found was not treatment, but rather a lack of research about the effects of hypoxia on the brain. This has been the underlying motivation for much of my research. Ray loved to think and talk about science. He was excited about science. He was curious about every aspect of memory, including spatial memory, memory for time and duration, item memory, and memory for the order of events, to name a few. He was always designing memory tasks and asking questions. He would come into the lab with an idea for a new experiment, and he would present that idea and then would immediately ask you what you thought. Would it work in humans? What were the potential problems? What things had been overlooked or needed to be included? After asking the questions, he would then listen. He wanted your input and ideas, even if they were not fully developed or even close to truly understanding the question. Ray would listen, think about what you said, and would ask more questions, making you think deeper about the topic or experiment. He would go home, continue to contemplate the ideas, and come back the next day with a new or modified design, and the process would start all over again. Ray would host lab ski days, especially during the winter conference on learning and memory held in January in Park City. In the days before high-speed quads, riding the lift to the top of the mountain took a while. If you rode on the lift with Ray, by the time you reached the top of the mountain, he had helped you design a new experiment to conduct. While I now treasure what I learned from Ray, as a graduate student, I did not always appreciate the extra work. After several rides up the lift with Ray, occasionally, instead of skiing right onto the lift at the bottom of the hill, I would stop to adjust my ski boots. This brief pause allowed me to share Ray, his love of research and development of new experiments, with my fellow graduate students, as then they would have the opportunity to ride the lift with him. In early research with Ray, we assessed the memory for lists of words, pictures, abstract pictures, and spatial locations in participants with amnesia and damage to the hippocampus. Hypoxia damages the hippocampus, which is a critical structure for the ability to form new memories. These studies assess the contribution of the hippocampus to these memory tasks. The participants with damage to the hippocampus had impaired memory for the items and for the order the items were presented. We found that selective damage to the hippocampus resulted in severe impairments in memory. This finding mirrored what had been documented in rodents with hippocampal damage. This research was the foundation for my future studies. Ray's enthusiasm for science was infectious, and his curiosity about the brain and disorders such as Alzheimer's disease interested me. I soon found myself wanting to understand how critical illness and other brain-based disorders affected cognition and psychological functioning. Lesson 1, be curious, ask questions. While in graduate school and early in my career, I worked at LDS Hospital with Lindell Weaver. Lynn is a pulmonologist and intensivist who studied the effects of carbon monoxide poisoning, as well as treatments to remove carbon monoxide from the blood and improve outcomes. Carbon monoxide is an odorless, tasteless gas that results from incomplete complete combustion of carbon-based compounds, such as wood, natural gas, and gasoline. Several early studies had shown that some people who were exposed to carbon monoxide can develop a syndrome called delayed neurologic sequelae. Delayed neurologic sequelae is where people can recover from the carbon monoxide, but several days to weeks later, they experience a significant decline in cognitive and neurologic function. Small studies had shown that hyperbaric oxygen improved delayed neurologic sequelae. Lynn was interested in understanding the effects of carbon monoxide poisoning on the brain, including its effects on cognition. One study I was a co-investigator on assessed whether treatment with hyperbaric oxygen after carbon monoxide poisoning would prevent or improve cognitive impairments. I was fortunate to be part of the research group headed by Lynn Weaver that designed and conducted a randomized, double-blind, controlled clinical trial that compared two treatments for carbon monoxide poisoning, hyperbaric oxygen, and normal baric oxygen, which is 100% oxygen administered by a non-rebreather face mask. Hyperbaric oxygen is oxygen administered under pressure in a hyperbaric chamber, which increases the oxygen levels in the blood and can repair tissues and improve functioning, including brain function. The study compared outcomes following either treatment with hyperbaric oxygen or normal baric oxygen. In this study, 3 treatments of hyperbaric oxygen or normal baric oxygen were administered over a 24-hour period. We found that 3 treatments of hyperbaric oxygen administered within 24 hours of carbon monoxide poisoning reduced the prevalence of cognitive impairments. The left side of the graph shows cognitive impairments occurred in 25% of patients in the hyperbaric group at 6 weeks, represented by the blue bar. 46% of the normal baric group had cognitive impairments, represented by the yellow bar. The reduction in cognitive impairments persisted at 12-month follow-up, with the right side of the graph showing 18.4% having cognitive impairments in the hyperbaric group, in the blue bar, and 33% of patients who had cognitive impairments in the normal baric group in the yellow bar. The results of this study indicated that individuals with carbon monoxide poisoning appeared to benefit from treatment with hyperbaric oxygen. Lesson 2, research can lead to new knowledge and discoveries. These discoveries can benefit others. Around the same time, I was also introduced to Aaron Bigler. Aaron was a pioneer and one of the world's experts on brain imaging following traumatic brain injury and its relationship to cognitive function. Beyond understanding that hypoxia can damage the hippocampus, I had very little experience using brain imaging and research. Aaron was instrumental in opening his lab to me and served as a mentor in quantitative neuroimaging. At the time, all quantitative brain volumes were measured by hand, which required extensive training. This is a time-intensive process. It took months to learn the boundaries for each structure and how to accurately measure the brain structures. Each study would take hundreds of hours of tracing the specified brain regions. This was a very complicated process. While more recently a number of semi-automated or automated methods to measure brain volumes have been developed, hand tracing brain regions was the gold standard at the time. Along with assessing cognitive outcomes following carbon monoxide poisoning, participants in one study underwent brain magnetic resonance imaging scans, or MRI scans as they are more commonly known. Students working in my lab traced brain structures on the MRI images to determine if there were lesions or atrophy, which represents loss of neurons of various brain structures. We found significant atrophy in the basal ganglia, which is involved in motor learning and other types of memory, fornix atrophy, which is involved in memory, and changes in brain white matter following carbon monoxide poisoning. The slide shows a view of the brain looking in from the face towards the back of the head, showing the parts of the basal ganglia labeled A, B, and C. The study also found that impaired memory and slow mental processing speed were associated with smaller basal ganglia volumes. That is, damage to the basal ganglia was associated with cognitive impairments. This information furthered the understanding of the effects of carbon monoxide on the brain. Aaron was a great mentor and always had room in his lab for more students and junior faculty. He was very giving of his time and his resources to further the careers of all those who worked with him. Aaron was always willing to help someone, add another student to a project, and share his expertise. He collaborated on many studies around the world, sharing his gifts widely. Aaron's life was guided by a saying from John Wesley, which in summary is to do as much good as you can to as many people as you can. Aaron set a bar high, exactly as a great mentor should. I have modeled my mentoring following Aaron's example. I have tried to share what I learn with students and individuals that I mentor. Lesson 3, do good, share your expertise, help others. There are almost 6 million patients treated in intensive care units, or ICUs, in the United States each year. Each of us, on average, will experience 1.7 ICU admissions in our lifetime. Over 700,000 individuals will require mechanical ventilation, and over 200,000 will develop acute respiratory distress syndrome each year in the United States. While many of these people will survive their critical illness, a large number of survivors who are discharged from the hospital will leave the hospital with new morbidities. These morbidities include physical weakness, cognitive impairments, new or worsening psychological disorders, including depression, anxiety, and post-traumatic stress disorder. This constellation of adverse outcomes is known as post-intensive care syndrome. The physical, cognitive, and psychological sequelae are associated with development of functional limitations, including reduced quality of life, an inability to manage daily activities such as self-care, paying bills, and managing medications, and what is known as financial toxicity. Financial toxicity in the case of critical illness consists of high medical bills, loss of income, including the inability to return to work. Financial toxicity, along with the psychological and cognitive impairments, create a significant burden for survivors. Knowing of my interest in the effects of hypoxia on the brain, Lynn Weaver mentioned to me that there was a group of patients who were critically ill in the ICU who developed acute respiratory distress syndrome. He wondered if maybe these individuals, given their respiratory failure, could have cognitive impairments similar to those that we observed following carbon monoxide poisoning. At the time in the mid-1990s, there was no information about cognitive outcomes after acute respiratory distress syndrome. Acute respiratory distress syndrome is a life-threatening illness. Approximately 30% of people who develop acute respiratory distress syndrome do not survive. In acute respiratory distress syndrome, the fluid fills the air sacs in the lungs, leading to difficulty breathing and reduced oxygen delivery to the tissues. It occurs in people who are critically ill or who have a serious injury. We designed a study to assess whether individuals with acute respiratory distress syndrome would develop cognitive impairments. In 1999, we found the majority of patients at hospital discharge had cognitive impairments and psychological symptoms, which contributed to reduced quality of life. 1 year after leaving the hospital, almost 80% continued to have at least one impairment in attention, memory, or slow mental processing speed. The cognitive impairments were associated with hypoxia experienced during their critical illness. This study, although small, was the first to document cognitive and psychological impairments in survivors of acute respiratory distress syndrome. In 2005, in a longitudinal study, we found that 73% of the study group had cognitive impairments at hospital discharge, with cognitive impairments occurring in 46% of the patients at 1 year and 47% at 2 years. These data suggest that for some participants, cognitive function improved over time. However, in almost half of the patients, the cognitive impairments persisted 2 years after they left the hospital, with little change after the first year. We also found almost a quarter of the participants had symptoms of depression and anxiety at 1 and 2 years. Following these studies and outcomes after acute respiratory distress syndrome, a group of investigators, of which I was part, designed and carried out a multi-center study that occurred in sites across the United States. The ARDS Network Long-Term Outcomes Study, or ALTOS study, followed patients in several ARDS network trials, including the Eden and SAILS studies. These studies included 41 hospitals and assessed physical, cognitive, and psychological outcomes in patients with acute respiratory distress syndrome. Patients were followed at 6 and 12 months. The table shows the cognitive results of the study. The yellow row shows the cognitive outcomes for the Eden study, and the blue or grayish row shows the cognitive outcomes for the SAILS study. The prevalence of cognitive impairments was 36 and 37% in the two studies at 6 months. The prevalence of cognitive impairment was 25% and 29% at 12 months. Strikingly, the prevalence of cognitive impairments was similar in both studies. Similar to our 1999 study, there was some improvement in cognitive impairments over time in some patients, but not all patients improved. The table shows the psychological results of the study. The yellow rows show the psychological outcomes for the Eden study, and the blue or grayish rows show the psychological outcomes for the SAILS study. The top two rows show the outcomes for depression. The prevalence of depression was 37% and 37% at 6 months, and 37% and 37% at 12 months. While the percent of patients with impairments is identical, this is not a typo, but rather a surprising finding. Across two different studies with different participants at 2 time points, the percent of patients impaired did not vary. The middle 2 rows show the outcomes for anxiety. The prevalence of anxiety was 45% and 46% at 6 months, and 42% and 41% at 12 months. The bottom row shows the outcomes for post-traumatic stress disorder. Post-traumatic stress disorder occurred in 26% and 25% of patients at 6 months, and 23% and 26% of patients at 12 months. The prevalence of psychological disorders varied somewhat by the type of disorder, depression, anxiety, or post-traumatic stress disorder, with the highest prevalence occurring for anxiety, followed by depression. While post-traumatic stress disorder had the lowest rates, a quarter of survivors had symptoms of post-traumatic stress disorder. There was no improvement over time in the prevalence of any of these disorders. The findings from these studies confirmed previous work showing a large number of survivors of acute respiratory distress syndrome have persistent cognitive impairments and new or worsening depression, anxiety, and post-traumatic stress disorder. These psychological symptoms persisted to 1 year. Subsequent data from other studies has shown the cognitive impairments and psychological disorders persist for 5 years or more after the development of acute respiratory distress syndrome. Further analysis of the combined data in survivors showed that psychological disorders can occur in isolation or can co-occur in survivors. Of the almost 700 survivors in this study who had acute respiratory distress syndrome, 2/3 had symptoms of either depression, anxiety, or post-traumatic stress disorder. Of the survivors with psychological disorders, 39 had 1 psychological disorder, 28% had 2 psychological disorders, and 33% had all 3 psychological disorders. For example, anxiety co-occurred in 18% of survivors who had depression. Anxiety also co-occurred with post-traumatic stress disorder in 7% of the survivors. In addition, psychological disorders can co-occur with cognitive impairments, not shown in this graph. The combined cognitive impairments and psychological disorders show the significant morbidities that are common in survivors of acute respiratory distress syndrome. In addition to cognitive impairments and psychological disorders, the burden does not stop there. Survivors continue to require health care after leaving the hospital, with its associated substantial costs. Many patients who were previously employed are not able to return to work. We also evaluated post-discharge hospitalization and health care costs during the first year after leaving the hospital. Of the 859 survivors, 98% utilized health care after hospital discharge, and 40% were hospitalized at least one time. The mean hospital cost was almost $19,000, with a range of $7,852 to over $46,000. Higher quality of life and physical activity were associated with fewer hospitalizations and lower hospital costs. Alternatively, worse depression and psychological symptoms were associated with increased hospitalizations. It is unclear why psychological symptoms are associated with increased hospitalizations. The costs for physical therapy and psychiatric visits were the highest in the outpatient expenses assessed and reflect significant physical and psychological morbidity experienced by these survivors. We also analyzed joblessness in survivors of acute respiratory distress syndrome. Employment is an important outcome, and it's associated with economic well-being, a sense of self, and quality of life. Of the individuals who were employed prior to their acute respiratory distress syndrome, 44% were jobless at 12-month follow-up, and 40% experienced a major change in their occupation. 43% never returned to working the same number of hours they worked prior to their illness. That is, in some, they worked fewer hours after their critical illness than they worked before their critical illness. Further, 58% received new disability. Functional impairments contributed to the unemployment. Joblessness or disability were associated with a decline in private health insurance. Finally, 71% lost earnings were estimated to be approximately $7,300,000 in this study, or an average of $27,000 per person, which was 60% of their pre-illness earnings. In sum, the effects of acute respiratory distress syndrome on employment was substantial. Results from other research groups are similar. Factors that are associated with delayed return to work include longer hospital length of stay and older age among non-white survivors. Alternatively, age was not a factor in white survivors, as the return to work was similar across age categories. Importantly, financial toxicity due to the health care bills, loss of income, joblessness, and loss of private health insurance is strikingly prevalent and adds to the substantial adverse outcomes of cognitive and psychological impairments following acute respiratory distress syndrome. In a follow-up study, we conducted a literature review and meta-analysis of return to work after critical illness. We identified 52 studies, which included over 10,000 previously employed ICU survivors. The pooled prevalence of return to work was 36% at 3 months, increasing to 64% at 6 months, and the highest rate of return to work was 68% in the 40 to 60-month range. Despite an increase in return to work, over time, return to work declined between 6 and 12 months. This suggests that some people who return to work experience subsequent job loss. This study confirms our previous findings showing 30 to 40% of previously employed survivors do not return to work after their critical illness. The increase in employment between 6 months and 60 months was only 4%. While return to work increases in the first 6 months, there are few gains in employment are made up to 5 years after the critical illness. In addition, these survivors also worked fewer hours, had substantial changes in their occupations, and subsequent job loss, which adds to the financial burden. Little did I know where that first study of outcomes following acute respiratory distress syndrome would lead me. There were only a handful of researchers that study outcomes after critical illness and acute respiratory distress syndrome when I began my research. Now there are over 50 studies that assess cognitive function. The field has exploded and hundreds of ICU outcome studies are published each year. This research has changed our understanding of the long-term effects of critical illness and acute respiratory distress syndrome. It has been the major focus of my research for the past 20 years. Lesson 4, take advantage of the opportunities that come your way. You will never know where they will lead you. More recent work has begun to assess interventions to prevent or improve long-term outcomes, such as reducing delirium, which is associated with the development of cognitive impairments. I have also collaborated with colleagues on how critical illness and caregiving affects family caregivers. Family caregivers can also develop post-intensive care morbidities and is known as post-intensive care syndrome family. Most commonly, the family caregivers experience depression, anxiety, and post-traumatic stress disorder. For example, in one study of 100 family caregivers, we found that a third of the participants had anxiety and approximately 15% had depression and post-traumatic stress disorder. The economic costs of family caregiving include out-of-pocket expenses and loss of income. Caregiving is still needed in a quarter of ICU survivors at 6 and 12 months after hospital discharge. The psychological changes are associated with financial burdens, associated with the economic costs of caregiving and loss of wages, reduced quality of life, and disruption in social functioning, and limitations in activities of daily living. These effects are substantial. The full importance and implications of research are often not fully appreciated until years after the initial studies are completed. In this presentation, I have shown that acute respiratory distress syndrome is associated with cognitive impairments, depression, anxiety, and post-traumatic stress disorder. This research, along with the research of other colleagues, suggests that many individuals with severe acute respiratory syndrome coronavirus 2, or COVID-19, treated in the ICU develop acute respiratory distress disorder. These individuals are at risk to develop physical and cognitive and psychological morbidities. Early research is showing survivors of COVID-19 develop cognitive impairments and other neurologic morbidities. Several studies have shown that COVID-19 patients admitted to the hospital develop new physical disabilities, cognitive impairments, and psychological disorders. There is a growing group of COVID-19 survivors whose symptoms persist long after they've recovered from the virus. The symptoms include fatigue, sensory loss, weakness, psychological disorders, and brain fog, or cognitive impairments. A recent study published in the Journal of Psychiatric Research found that cognitive impairments occurred in patients who had recovered from the virus, including individuals who had mild cases and were not hospitalized. Studies are ongoing to assess the long-term effects of COVID-19, but research to date suggests that COVID-19 is associated with new significant morbidities. Lesson 5, the implications of your work may not be apparent for years. In this presentation, I have touched on a few of the important research results over my career. These studies show that many disorders can adversely affect the brain and have profound implications for both individuals who experience them and their families. While I've been successful in research, the success could not have happened without the exceptional students who worked in my lab and the many colleagues and collaborators I've been privileged to work with over the years. Of great importance are the many mentors who have supported and guided this work, a few of which I mentioned in this presentation. I am grateful to have the opportunity to share this research, and I express my gratitude to the many people who influenced me and helped me along the way.